to solving the residual sleepiness puzzle, managing daytime sleepiness in treated OSA patients, a webinar produced by Sleep Review and made possible via an independent educational grant from Axum. I'm Sri Roy, Chief Editor of Sleep Review. I extend a warm welcome to the hundreds of healthcare professionals in our audience today, and a shout out to BRPT credential holders who are watching this event live on November 20th, 2025. If you watch for at least 15 minutes, we'll send you a certificate by December 12th that is good for 1 CSTE credit. Everyone in attendance will get a link to the recorded event tomorrow. The recorded event is not eligible for CSTEs. Both presenters' conflicts of interest disclosures are available in the handout section of your screen. Now I am thrilled to introduce today's first presenter. Stephen P. Gradney, MD, is a sleep medicine department head and medical director of Mercy Clinic Sleep Medicine in Springfield, Missouri. He is also sleep service line physician lead at Mercy Clinic in Missouri, Arkansas, Oklahoma, and Kansas. He completed a sleep medicine fellowship at Indiana University School of Medicine. Welcome, Dr. Gradney.
Thank you so much. What a nice introduction. Thank you all for attending, and really excited to talk about this important issue today. So we all see obstructive sleep apnea patients, and I know that there's already been two series in this, or two presentations in this series talking about residual sleepiness. And so I'm just going to cover a small part of residual sleepiness today. And hopefully you guys find it helpful and have some great questions for us at the end. So let's get started. All right, if I can advance my slides, there we go. So as Sri already said, Steve Gradney, Medical Director at Mercy in Springfield, Missouri, also Assistant Professor at the University of Missouri School of Medicine. And I oversee a lot of sleep departments in an administrative role, as you already mentioned as well. But I do still see patients in the clinic and take care of a lot of obstructive sleep apnea patients. So here are my conflict of interest that are building a little bit differently than I had hoped, but here we go. And then this is our outline for today. So I'm going to be talking about how to evaluate the current therapy that your OSA patients are on. And we're really going to focus on the most common therapy, which is CPAP or PAP therapy. There are numerous other therapies for obstructive sleep apnea now, and that's growing quickly over the next year or two. But since PAP is the most common, I wanted to get the most bang for your buck today and talk about that in particular. Then we're going to talk about optimizing that therapy, things that you can do to help improve it that may in turn improve your excessive daytime sleepiness. Then we're going to talk about some confounding sleep disorders that may be the cause of, or at least contributing to, some residual excessive daytime sleepiness. And then we're going to talk about collaboration for addressing some comorbidities that could be contributing to EDS as well. And then Dr. Bogan is going to step in and talk to us about a different aspect of this. And then we'll have time for some question answers. All right. So the first section, as I said, evaluating PAP-based therapy. And we're really focusing just on PAP because the field options are growing so much that we really didn't have time to talk about everything today. So the first thing I'd like to talk about is assessing what PAP modality you're on. So here's just a list of the main ones. We got APAP, CPAP, BiPAP, auto BiPAP, BiPAP ST, ASV, auto ASV, VAPs, and non-invasive ventilators. As a sleep specialist, we should be capable of using all of these options. Certainly some people feel more comfortable than others if they come from a pulmonary background. But even if we're coming from a neurology, family practice, whatever background, this is full spectrum sleep medicine, and we really should be able to use all of these modalities. So the first thing to do whenever you're assessing EDS in a patient who's already treated is look at, do I have them on the right treatment? Do I have my PAP modality correct? And so we'll talk a little bit more when we talk about optimization, about what to consider in that realm and how to change it. But the first thing is always just think about this baseline. You may not have the right modality. The modality is often dictated by the diagnosis, and we're going to talk a little bit more about that whenever we talk about optimization as well. The next thing that comes on your download is hours. How long is the patient using it? So the real question is, how long is long enough to improve excessive daytime sleepiness? So there's some data out there that suggests that subjective sleepiness may be improved with 4 hours alone, but it really takes longer than that to get to objective improvement in sleepiness. And honestly, this varies from patient to patient. You may have some patients who are using a full 8 hours a night, still have residual sleepiness, or the other side of that may be true as well, where they may be short sleepers and get benefit from the less. It's widely accepted that there's a dose response relationship whenever you talk about PAP, meaning that the longer they use PAP successfully, the better the response is, so the less EDS you're going to have. And while that is true in some patients, not all get that response. And that may actually be more true for some specific symptoms and medical risk, like increased cardiovascular risk, increased stroke risk, dementia risk, etc. And so ours is not the entire, I wouldn't hang my hat in solely on this metric. The next thing we typically look at is how many days are they using it? So we all know the insurance criteria. They have to be using it at least 4 hours for at least 70% of the days. Well, is 70% of the days enough to get rid of the patient's EDS? The answer is likely not. If we took you and said, hey, you're going to get a good quality night's sleep 70% of the time, I think we all intuitively can see that that would leave us with some residual sleepiness, and we wouldn't be fully rested and optimized. The other thing I want you to do when you're looking at these downloads is look at daily variation, right? A lot of times you can figure something out right there. If you see that the patient's sleeping 10 hours on the weekends, and then they're limiting themselves to 6 hours during the week or 5 hours, that gives you a clue right there of, hey, some of this patient's residual sleepiness is actually just because of their schedule. Their sleep opportunity may be suboptimal. All right, let's continue down this road. There's a lot to be gleaned from the download that you can get from PAP therapy. The next thing we typically look at is the total sleep time. So what we have to realize, and I think everybody knows this, is that the time the patient used PAP therapy does not equal the total sleep time in many patients. So a lot of times I'll look at a download and I'll tell the patient, hey, I see you're averaging about 5.5 hours per night on here. That's not very much sleep. What's going on? And they say, oh, well, don't worry, doc. I usually get a couple hours more. I just take it off, early in the morning and sleep another 2 hours. So I'm really getting about 7.5, 8. Well, that's fine. I understand that they're getting a little bit more sleep, but in reality, the PAP therapy time may equal effective total sleep time, meaning that that extra 2 hours that the patient is getting is actually not effective in relieving the patient's sleep burden, sleep drive, and that may be leaving them with some excessive daytime sleepiness. So keep that in mind. The next thing is to look at the pressure. So a lot of patients are on APAP these days, and so you really want to be paying attention to the median and the max pressure that they're hitting. If they're maxing out at the top end of their range, they're clearly not, they're having some time where they're getting ineffective therapy. If the median is far from the bottom of the range, which again, we're going to talk about this a bit more whenever we talk about optimization, they may not be getting adequate therapy for portions of the night. Look at the pressure and just do a gut check. Is it appropriate for the clinical scenario? Do you have a patient with a BMI of 50 who had an AHI of 100 and they're on a CPAP pressure of 8? That's probably not appropriate for that clinical scenario. Vice versa, do you have a small, petite patient who had mild sleep apnea and they're on a pressure of 20/15? Again, probably not appropriate for the clinical scenario, We all have anecdotal cases that required atypical pressures, but in general, I would take a second look at cases like that. Is the range tight enough? Again, if the range is set at 4 to 20 and the patient's averaging 17, well, it takes a long time for that machine to get from 4 up to 17. And so they have a portion of the night, maybe repeatedly, if they're waking up or discontinuing their machine or pausing it or getting up to go to the restroom, they may have several portions of the night where they're getting insufficient therapy while it's trying to ramp up to the appropriate pressure. And so you need to probably tighten that range down. And is the pressure causing problems? Is it high enough that it's causing central sleep apnea by overventilation? Is it causing leak? Is it low enough that it's leaving the patient with air hunger or just inefficient treatment? Let's talk a little bit more about leak. So we should all be aware of the concept of intentional leak, acceptable leak, and then when leak is a problem. Most of our downloads will give us a median, a 95th percentile, a maximum. To be honest, different companies calculate these a little bit differently. In my clinical experience, I don't find the 95th or the maximum leak to be clinically useful. And so I really go off of the median leak for the most part. I think there's a whole other discussion to be discussed about the 95th percentile, but we won't delve into that right now. And then you have to decide, is leak a problem? Just because leak is present does not mean it's a problem. Is leak a therapy problem where it's leaking so much that it's making your PAP ineffective? Okay, then we need to make a change. Is it a patient problem? It's leaking even a little bit, but it's disruptive to the patient. Then we need to make a change. Is it a bed partner problem where the patient sleeps fine, but the leak is disrupting their bed partner? If any of those three are present, then we need to make a change. But if all of those are a no and we have leak, I don't go chasing it. That is not what is leading to your residual excessive daytime sleepiness. And so you're going to cause yourself and your patient a lot of strife trying to chase down basically what is inconsequential leak. And so just keep that in mind. All right, keep moving on here. The next thing that we like to assess is EPR. So the concept that I really want to get across here, and you guys all know it, I'm sure, but EPR is BiPAP. The only difference is that EPR maxes out at 3 and BiPAP is 4 or more spread. The big issue that you want to assess here is that BiPAP setting, is that EPR causing a problem? It does increase ventilation to a small degree, and so you can blow off a little bit of extra CO2 and can lead to some additional CSA. This is particularly relevant in those patients who have mild disease with some underlying cardiac dysfunction. Those patients are pretty sensitive to this, and even a little bit of BiPAP in the form of a EPR of 3 can tip those guys over the edge and give you residual events that might cause some residual sleepiness. So just be aware of that. In my opinion, really, I think EPR is overused a little bit. AHI is obviously what we're going to be looking at. So you need to really think about what is your goal AHI. So sometimes we'll say less than 15 is if the patient's asymptomatic and otherwise doesn't have any big medical comorbidities. However, by definition in this discussion, we're talking about patients who have residual excessive daytime sleepiness. And so all of them are symptomatic. And in that case, where your AHI is below 15, but the patient is symptomatic, you really should be trying to optimize further and get that AHI down to 4 or less. It also tells you a difference between how many apneas versus hypopneas versus RERAs are on the download. And there are some people who believe that you should adjust the spread or the inspiratory pressure versus the expiratory pressure based on whether it's an apnea versus a hypopnea versus a RERA. And again, that's a discussion sort of, I think that we could get into, but just be aware of, are you looking at what types of events are left? To that point as well, it oftentimes tells you whether they are central versus obstructive. That's very important because those are going to require different interventions. If you see that it's all obstructive events left, then you're going to probably need more pressure support. If it tells you that they're all central events left, well, you may need to lower the pressure or switch your modality completely. As far as Cheyne-Stokes breathing, several of the main manufacturers will give you some of that as well. And again, those are central events. So you're going to need to consider that before you make any pressure changes and before you make any modality changes. Advanced modalities is another thing that, again, I listed these at the beginning of this section. It's beyond the scope of our discussion today, but just know that there are multiple additional settings on these devices like VAPS and NIV that you can adjust the trigger volume or the trigger sensitivities, the slopes for the inspiration, expiratory phases, the tidal volumes, etc. And all of that can play a part in how well therapy works for your patient, how well it's tolerated, and whether or not they have residual EDS. All right, so I would normally pause for questions here, but I've been told that we wait till the end for that, so I'll do that. So let's move on to PAP-based therapy optimization. All right, so I already alluded to several of these things, but the first and biggest one is get the diagnosis correct. I cannot tell you how many times I've had patients come to me with residual sleepiness, with residual elevated AHI, or just as a previous PAP therapy failure, just couldn't tolerate it. You dig a little bit into their previous PSGs, their previous diagnosis, their previous therapy, and you can see either that they had residual central apneas or that really they had central apnea from the very beginning on the original test. Get those patients on the correct modality that actually addresses the CSA or the hypoventilation, and all of a sudden that patient no longer is a CPAP failure. They tolerate it just fine. And so this is a big deal. I think we are under-diagnosing central sleep apnea. We are under-recognizing hypoventilation in our patients. And so just make sure you get the diagnosis correct. That's going to lead to getting the correct modality. So we know that CPAP does not always work for CSA. We know that BiPAP often worsens CSA. And we know that hypoventilation and that elevated CO2 that can happen with hypoventilation, which, by the way, absolutely can lead to excessive daytime sleepiness. We know that that doesn't respond to CPAP or BiPAP very well. Sometimes you put these giant spreads on the BiPAP to help with this, and honestly, they're just not well tolerated, and they're not that effective all the time. So you may need something like VAPS, volume assured pressure support, to really know how much ventilation you're getting for that patient. Residual hypoxemia is something that I think is missed quite a bit as well. When you look at the download, AHI looks good, patients using it, but those things do not tell us the oximetry. And so you could have a patient who continues to have some persistent hypoxemia that could be contributing to excessive daytime sleepiness. So if your patient looks good on your PAP download, but is still having EDS, I do recommend running an overnight oximetry. Always make sure you compare the overnight oximetry data to the PAP compliance data. I've had more than one patient who was a bit confused and didn't use their CPAP on the night of their oximetry. Oximetry obviously looked terrible, but when I compared it to the download data or the PAP compliance data, I said, hey, you weren't using your CPAP, what's going on? And if they do have residual hypoxemia, my understanding of the guidelines at this point from CMS are that they unfortunately do still need a PSG to qualify for O2, if it's bled in with PAP therapy or not. All right, hypoventilation. So I really would strongly consider an in-lab titration with CO2 monitoring if you're worried about this or you think your patient's at risk for this. Although some DME companies are now offering home CO2 monitoring free of charge. And so this is something to consider as well. in lieu of the availability or approval of in-lab studies. Identify different endotypes of sleep apnea. So again, this is best done on in-lab testing, although some home units can provide some of this data. And you can even glean some of this from oximetry data if you really, kind of look at it and squint your eyes a little bit. So REM-specific OSA, a lot of times these are young, obese females, and they can really benefit from set pressures that are able to control their REM disease burden. Because what happens a lot of times if you put them on something like APAP, they will cruise along at a pressure of 5, doing great whenever they're in non-REM sleep. And as soon as they hit REM sleep, they're a disaster. They need much higher pressures. And it takes enough time or effort from the device to go from 5 to 12 that they actually wake up. And their entire sleep architecture has been disrupted. Their REM cycle has been disrupted. And those patients then, even though their AHI overall looks low, they're actually having quite a bit of sleep fragmentation, and they can have residual sleepiness. Same principle when you talk about positional therapy. Some patients look great when they're on their side. As soon as they roll to their back, they look terrible and they need much higher pressures. And the APAP algorithms simply can't get there fast enough to avoid sleep disruption. So these are endotypes that I would say probably do a lot better on set pressures set at the maximum amount they would need to handle them in the worst scenario, either REM sleep or supine. Again, we already sort of talked about the modality several times here. You can tell I actually really think this is a big deal. And so there is some data suggesting that BiPAP or EPR allows patients to have better compliance. I believe this is overutilized at the expense of many of these other considerations and interventions, and really find this to only be, not only, but mostly effective whenever it actually addresses the underlying pathophysiology, that being hypoventilation, true expiratory weakness in a COPD patient, etc. Situations like that. Right. So when should you use titrations or PAP naps? Well, both are great tools to help you optimize your PAP therapy. The choice is really driven by what do you need to know. And so PAP naps are really good to just for patients who are struggling with a little bit of tolerance, who are having excessive leak, who just don't like their interface, their mask, or who might have some excessive mouth venting. If you can get a PAP nap approved through their payer and you have the staff to get it done, these can be very helpful. If you need more detailed information, let's say that you are worried about REM-specific sleep apnea, you're worried about positional apnea, you're worried about Cheyne-Stokes breathing, etc., really you should be pushing to have those patients come into the lab. Great. So again, we're going to talk about pressure. So air hunger and ramp intolerance often develops after the patients acclimate to therapy. When they first start, they love the fact that they can start at a pressure of 4 or 5. But once they're acclimated to that actual therapeutic pressure they need of 10, well, 4 or 5 really doesn't feel very good anymore. And so a lot of times I will have to discontinue the ramp feature and lower the bottom end of their pressure range from 4 or 5 all the way up to close to their therapeutic pressure, if not right at it. Conversely, some patients actually require less pressure whenever you get them acclimated to therapy. A lot of that airway inflammation, edema, irritation, and stickiness kind of go away after we've treated them for a few weeks with PAP therapy. And they may actually say, hey, I don't feel comfortable with this much pressure. And we may be able to lower them down even into ranges that didn't look good on the titration previously. Because remember, when they did the titration, they still had an inflamed edematous airway. So just keep both of those things in mind, that what they start out on may not be the optimal pressure for them later because of multiple reasons. And then we're always gonna look at the interface on how to optimize this. The mask make a big difference. Because of situations where a full face mask really may be putting some additional pressure on the jaw and causing more collapsibility of that airway, I do recommend that we start everyone with a nasal interface, even if they report that they are mouth breathers. That you still try a nasal interface first. Many patients will close their mouth once you open up that airway with a nasal mask. Only move to full face mask if needed. You may need a chin strap, you may need mouth tape. Nasal dilators can really be helpful in a lot of patients who suffer from nasal congestion or anatomical nasal issues. I put in parentheses here, there's a nasal dilator that I love and I use in my patients a lot. It's called Mammoth. And from personal experience, I went through utilizing a lot of nasal dilators with exercise and things like that. And the Mammoth dilator has really been something that my patients have responded to very favorably. And they can use it with their PAP. Nasal steroids, Astelin, saline rinses, all of that can play an important role in optimizing PAP therapy. I didn't put it on here, but don't forget your ENT colleagues. There are a lot of progressive ENT colleagues out here who are doing procedures that can really make PAP work better for a patient and make it better tolerated as well. I put dash removing vasoconstrictors. Man, this is just a pain. Afrin works so well. My goodness, it's amazing. Whenever I have a cold, I love it. But it has caused me so much headache in my clinical practice of sleep medicine, getting these guys off of it. If you have a patient who starts out with PAP therapy, does great at the beginning of the night, and then says they wake up in the middle of the night and absolutely cannot use it, always ask them if they're on a vasoconstrictor nasal spray. I've seen this multiple times. And once we get through the pain of getting them weaned off of those medications, they are then able to tolerate their PAP therapy all night long. It's really the rebound congestion that's causing them to have intolerance. If they have skin irritation, educating them about the use of mask covers, educating them about the use of strap covers if they're having facial indention, things like that, that can make a big difference in their ability to use this. Finally, know when to stop trying to optimize PAP. So we have other options for a reason. Things like medications now with Zepbound, things like hypoglossal nerve stimulators, things like surgical interventions. There are things like mandibular advancement devices, and the dental colleagues are getting better and better at that. Know when to stop pushing PAP. If you don't, then what will eventually happen is that your non-adherent or struggling patient is going to stop you, and you're not ever going to be able to help them in any way whatsoever. So make sure you meet the patient where they're at, work with them. I try all these things for PAP, and I strongly encourage PAP, but I know when to quit and I know when to move on. Some patients just have residual sleepiness that has been caused by neurologic damage from the physiologic strain of OSA before we got to them. No level of OSA therapy, regardless of what type, is going to be able to resolve that EDS. That is going to stay with them, and that is something that we're going to need to treat. And Dr. Bogan is going to be kind enough to talk to us about how to treat those things in the next session. All right, confounding sleep disorders. Let me look at my time. Oh, I'm running out of time. All right, we're going to go through this quickly, guys. Behaviorally induced insufficient sleep, social jet lag. The biggest issue, just remember to ask. And then whenever the patient just sort of refuses to increase their total sleep time, but keeps coming back to me complaining of excessive daytime sleepiness, I do sometimes consider withholding additional testing or therapy until the patient shows some objective improvement in sleep opportunity, either through a PAP download showing that they're using therapy more often or through actigraphy. So just keep that in mind. Sometimes you have to draw a firm line before you go chasing things that there will be no additional answer to. Always review the list for sedating medications, including sleep aids. A lot of our sleep aids have next day carryover effects, whether the patient believes that or not. Look for supplements. Magnesium glycinate's gotten so popular, and I've had several patients who had complained of residual sleepiness the next day, didn't realize that their magnesium was actually causing some of that the next day. Fatigue, the differential is huge. It was previously covered in another talk. Just make sure that you're looking for that and that you're getting them to the appropriate person to address that. Disorders of central hypersomnolence, narcolepsy type 1 and 2, and IH. Just know that over 50% of those patients actually have OSA, and you're going to have confounders there about what's causing the EDS. So we're not going to get into sort of some of these other points, but when to test, when not to test, when to get them off of medications, when to leave them on medications, etc. I'm probably could talk another 30 minutes about all of that. Happy to do so if you guys want to bring me back. Co-ROSA, so comorbid RLS and OSA. So these patients have statistically worse EDS than patients with OSA alone. Just remember to ask, remember to follow the RLS guidelines. Same thing with circadian rhythm disorders. Difficult to assess, but important. Consider melatonin, light therapy, sleep hygiene, scheduling. I'm going to put a plug in here for the Luminet visor. Light therapy is very hard to adhere to, guys. I used to practice and live in Alaska. I used a lot of light therapy, including on myself. The Luminet visor was a godsend. It was really made it easier for me to utilize light therapy and for my patients to utilize it. Shift work disorder, so think of it as a circadian rhythm disorder in a way, but there are very difficult situations, especially if they have swing shifts, etc. What I tell patients is this, is that unfortunately, we often have to have an unnatural solution to this unnatural sleep cycle. So that sometimes will include utilizing both sleep aids and wake promoting agents. Final section here is, again, just putting a plug in here, make sure you're looking for sedating medications. One difficult thing for us as sleep providers is we will oftentimes see patients on sedating medications that we're not managing, and we really need to be reaching out to the people who are managing those. But we have to have an understanding that there may not be better options. If there aren't better options, then honestly, it is the responsibility of the person who's prescribing those medications to address the side effects. So if you have somebody who's giving your patient a very sedating antipsychotic medication, a very sedating opioid, and then they're sending it to you to address the excessive daytime sleepiness that you believe is caused by those medications, it's perfectly reasonable for you to send them back and say, this is a side effect of your medication. You should be handling this. And that is best practices for them as well. Obesity it can cause EDS in and of itself. Aggressive management is warranted for many reasons. Just think about the new GLP-1s are now part of sleep medicine. And so keep those in your mind. CHF, make sure you're working with your cardiology colleagues. Those patients often have EDS, but remember they often have CSA and complex sleep apnea. So make sure you got that diagnosis right. Same thing with chronic renal failure. Unfortunately, these patients can have RLS and central sleep apnea. And sometimes that central sleep apnea can wax and wane. If you have patients who are on hemodialysis, sometimes right before they get dialyzed, they have terrible CSA. And then once they get dialyzed, now they're back to obstructive. So you really need a dynamic device like an ASV that can help both conditions. And finally, psychiatric disorders. Just make sure you are connecting with your local psych providers to get the patient the care they need. All right, I'm 4 minutes over. Sorry, Sri, but thank you guys all for your attention. Hopefully this was helpful, and I'll stick around to answer questions on the back.
Thank you, Dr. Stephen Gradney. I was definitely not going to interrupt. I was watching that very intently. But thank you for helping us optimize CPAP therapy parameters, identify comorbid disorders. That was great. He mentioned a few times about the previous presentations. There were 2 presentations together in one previous webinar, and I will put that in the chat in just a moment for anybody who may have missed that one. It was about 2 months ago, but the recording is still available. For now, I am pleased to introduce today's second and final presenter, Richard K. Bogan, MD, FCCP, FAASM. He is the principal owner at Bogan Sleep Consultants in Columbia, South Carolina, and an associate clinical professor of the Medical University of South Carolina. He is a former chairman of the National Sleep Foundation. Welcome, Dr. Bogan.
Much, and certainly appreciate Dr. Gradney's presentation. He covered a lot of material there. I thought what I would do is step back and very quickly remind us of some of the previous discussions and recognize that there's certain endotypes and why are we sleepy? Why do people have abnormal breathing? And of course, we have a circadian rhythm, which Dr. Gradney alluded to in terms of shift workers and other delayed sleep phase individuals who tend to want to stay up late and sleep late, who are also tired. But I wanted to remind ourselves about these sleep-wake processes and the fact that sleepiness is very prevalent in the general population. Probably 30% of adult population has sleepiness, most of which is behavioral, but it can be certainly intrinsic. I wanted to remind us that these alerting pathways are primitive pathways with redundancy to help keep the brain awake. And of course, orexin is a very important neuropeptide that downstream stimulates other alerting pathways through the thalamus and stimulates the cortex. And then during the day, when the neurons are active, we build up a chemical in it called adenosine, and that's what makes people tired, typically. Then at night, when the sun sets and our eyes pick that up, we go to sleep. We make the neurotransmitters GABA that turn the brain off. And you can see these complex neural circuits that basically have redundancy to stabilize the state of wakefulness and sleep, with the red area being the orexin and the blue area being the GABA inhibitory that lights up at night to turn the brain off. And then when we reduce sleep, we get rid, the neurons turn off, and we get rid of the adenosine, the waste stuff. If we don't sleep long enough, we don't get rid of it. So I like Dr. Gradney's discussion about, if you don't get enough sleep, you're still tired. And oh, by the way, you build that up so you can accumulate it over time. So I think it's very important that individuals get enough quality, quantity, and continuity of sleep. We know that if you disrupt the continuity of sleep within certainly every 5 or 6 minutes, and if you do the math, 5 into 60 is 12. If you disrupt sleep 12 to 15 times an hour, then the likelihood of being non-restorative sleep existing certainly goes up. We talked about the Epworth score. I'll come back to that in a moment, but you all know the Epworth score in terms of a reference for looking at excessive daytime sleepiness. My Epworth score is 6. I'm kind of proud of 6. But when people are sleepy, they present in all kinds of symptoms, and not only sleepy but tired, but they also have trouble with executive function and mood and other situations that are important. I won't spend any time on this, but you can see when you have increase in airway resistance. So at night when you make GABA, muscles relax, the airway collapses, airway resistance goes up, and when it does, we hypoventilate and get oxidative stress, or we stop breathing, or we wake up and we disrupt sleep. And so all of those will interfere with the homeostatic drive of sleep. And of course, it creates havoc with us in terms of sympathetic tone and inflammatory mediators in the body that might cause sleepiness. Well, as Dr. Gradney said, we've all treated these patients with sleep apnea, and they come in, they're tired and they're sleepy, and we approach them from 2 perspectives. One perspective is we want to reduce morbidity and mortality, but the other is that we want the patients to feel better. They have to have adequate quality, quantity, and continuity of sleep in order to get rid of the adenosine and to have normal daytime function. But some of the patients are still sleepy, despite everything we do. And there are people, and Helen Weaver did this study from Northwestern, and Dr. Gradney alluded to this, that in terms of there's a dose-response relationship. So she looked at Epworth score, multiple sleep latency tests, functional questionnaire, functional outcome sleep questionnaire, and there was a dose-response relationship in terms of using CPAP. But she identified patients, despite using CPAP in excess of 7 hours with adequate efficacy, who still had sleepiness. So who are these people? So when the patients come in, our goal is obviously reduce morbidity and mortality. What's your AHI? What's your download look like? But also, how do you feel? How sleepy are you? Are you napping? Are you dozing? What is your Epworth score? And why are these people still sleepy? And despite the fact that they're using their CPAP in excess of 6 hours, maybe they need more sleep. But we get some hint, and you've seen this before, where they took rodents and exposed them to oxidative stress, and lo and behold, oxidative stress produced injury to some of these alerting pathways, particularly dopamine, but also orexin pathways. So there's evidence that oxidative stress may explain this. And then when you when you sleep deprive animals, you fragment sleep, you can also see changes in these monoaminergic amines that would suggest there's organicity. As Dr. Gradney said, there may be some neuronal injury that may contribute to this sleepiness. And the locus coeruleus, obviously, where we make norepinephrine, which is a very important neuropeptide to maintain wakefulness, is part of the problem. These are the mechanisms of action. I won't spend much time on this, but all these monoaminergic amines produce postsynaptic stimulation and help keep the brain awake. And one of the theories is if they have apoptosis, oxidative stress, and injury, then we may have residual daytime sleepiness, even in these individuals who are adequately treated and using their CPAP. And we've ruled out circadian misalignment, insufficient sleep, concomitant medications, comorbid depression, and also ruled out narcolepsy and idiopathic hypersomnia. Some of these people are still sleepy. Dr. Gradney mentioned something about weight loss, and obviously there was a study done with tirzepatide, and in those individuals, when you looked at the change in the AHI in these individuals who had obesity and obstructive sleep apnea, and some had diabetes, you can see that there was a substantial reduction in the AHI over a 52-week period of time. So patients lost 40 to 80 pounds. I have another slide on that. You can't really see it very well, but the whole point of that is that individuals who lost substantial weight, when we looked at their residual AHI, many of them were less than 5, and many were less, up to 50% had AHIs less than 15 and were not sleepy. We sort of think that the medical risk is at that level of 15, and particularly if you're 15 and above and you're sleepy, we think the medical risk is higher. So the point of this is, when we think of the endotypes of these individuals, there are different endotypes. Some individuals are arousable. You increase airway resistance, they wake up. And their brain has said, this is too hard to do, wake up and breathe normally, or don't work so hard. Some hypoventilate, as Dr. Gradney pointed out. Some obstruct, and some have oxidative stress. So there are these different endotypes that occur, but what we do know, the age and weight are modifiers. So as we get older, our muscles collapse more, and in fact, the prevalence of obstructive apnea is much higher in the older population. It's north of 20% in the moderate to severe category in people over 65, and north of 40% mild is the threshold of an AHI of 5. So these individuals are having problems, and if we lose weight, when you lose weight, the neck gets thinner, the muscles get leaner, you have less pressure on the diaphragm from weight. And so in individuals, particularly endotypes who tend to hypoventilate, we may see significant improvement with this weight loss in both in the AHI as well as clinical symptoms. How much of that's weight loss, how much of that's improvement in airway resistance, mass loading of the diaphragm remains to be seen. Importantly, some of the patients still have sleepiness, and there was a great review of the Delphi group, which was an international group that looked at residual sleepiness in individuals with obstructive sleep apnea, with guidance of, say, who are these people, how do we manage them, how should we treat them or not. And the point of that is that we probably should treat. These individuals are still sleepy, and they'll come back to you and say, Doc, I'm using the CPAP, and you told me my sleepiness was going to go away. Well, it's better, but I'm still sleepy, and this is how the sleepiness is affecting me, and can you help me? And this was a graph showing the solriamfetol measurements, and solriamfetol is one of the drugs that we have approved by the FDA to treat residual sleepiness in OSA. One is modafinil, the other one is armodafinil, and then we have solriamfetol, which is the newest one. This particular drug is excreted through the kidneys, not metabolized by the liver, does not affect the 3A4 system, so we don't worry so much about birth control pills in females with this particular molecule. It's been approved for both narcolepsy and has been approved for OSA with residual sleepiness. Reminder, it does not treat the OSA, it treats the sleepiness. But as we approach our patients, reduce morbidity, reduce mortality, and improve quality of life in these individuals, this is a way we can do it. And when you look at the data from the research studies, there was a huge effect size. And by effect size, I mean when we looked at the effect on the Epworth score in that bottom graph, the patients had a substantial reduction in excessive daytime sleepiness. A change in the Epworth score of 7 and 8 is a big signal. And these individuals had substantial baseline excessive sleepiness. I think they were around 16 or so on their Epworth score, which means they were very sleepy. We certainly can affect function. And then we did the MWT study. The MWT, dark room, lights out, see how long you can stay awake across the day. And you look at the placebo group in graph A, the very bottom, not a real signal, but when you compare placebo to these different doses of 37.5 up to 300 milligrams, though 300 milligrams was not approved, 150 milligrams is the maximum dose, you see a big signal. I mean, there's a really big signal there. We call it a big effect size, which separated from the placebo group and showed improvement in the alertness in these individuals. Parenthetically, I will say that in the trials, we insisted everyone use CPAP because we were obviously wanted to reduce morbidity and mortality. There was a group of individuals who did not wear CPAP who were sleepy, and we actually studied them with solriamfetol, and we saw efficacy and we saw the same side effect profile. And the side effect profile is what you typically see with awake promoting medications. I mean, headache, dizzy, nausea, or some mood change, anxiety, and in a few people, some increase in heart rate or blood pressure. So we always watch for those, but there was no difference in the treated and untreated group. That doesn't mean you use this drug in untreated sleep apnea. We do everything. And as Dr. Gradney said, we use oral appliances, we use hypoglossal nerve stimulators, we use upper airway modification if indicated. These are issues that we have with these individuals. Now, the other is comparative effectiveness. I'm not a big fan of meta-analyses, but the whole point of this particular graphic is to show that pitolisant, which is a histamine stimulating, it's actually an H3 inverse antagonist, but what it does, it upregulates histamine signaling. And you remember that was one of the monoaminergic means they have to keep the brain away. It's been studied in Europe. It's not approved for treating residual sleepiness, but I included the graph here. So we have pitolisant, placebo, modafinil at 200, 400 milligrams, and solriamfetol. The point is, these drugs have been studied and showed efficacy in these individuals that showed some enhancement of alertness in the individuals. So as Dr. Gradney said, CPAP is the best treatment. If we're going to try to improve our CPAP adherence, we may add upper airway appliance to reduce the pressure. We may proceed with weight reduction. Patients may do very well on their side compared to their back, so we may try positional therapy. So these are all options. And then weight loss will obviously lower the pressure, and then some of the patients are actually able to get off the therapy. So in summary, clearly obstructive sleep apnea is not healthy, has a huge effect on CNS function and other inflammatory mediators and autonomic function. And CPAP is still the best therapy. We have other ways to augment and improve CPAP adherence, but despite optimal therapy, we have patients who have residual daytime sleepiness and functional impairment. And now we have treatment options for that. So I know I went through that very quickly, but I wanted to save some time for questions, and I'm happy to participate in answering those with Dr. Gradney.
Excellent. Thank you, Dr. Rick Bogan, for that insightful presentation. I did want to touch on maybe two things before we jump into the audience questions. But audience members, if you do have questions, please put those into your Q&A box now. We will get to those in just a minute. Dr. Bogan, can you discuss your long-term EDS monitoring protocols? Like, do you recheck somebody at every visit by giving them the Epworth? And do you find that the EDS stays away or does it return?
Oh, absolutely. Every time they come in, we are, again, reducing morbidity and mortality, but also improving quality of life. So we talk up to our patients. We get the downloads, as Dr. Gradney said. So we look at hours of utilization and efficacy, always looking at that with a degree of suspicion, because the device, as you know, effectively has a pneumatic in it. So it's measuring flow of air, pressure gradient with a fixed resistance, and it's calculating tidal volume, respiratory rate, and minute ventilation. But I would encourage anyone who's managing patients with these devices that they understand the algorithm the device is using, because it uses a baseline, what is normal, and then it decides if this is abnormal based on that baseline. So in order to trust that data, a good download and good knowledge of the algorithm is important to make sure we have adequate efficacy. And then the other is we ask patients about quality of life. So the patients are not just an AHI. They sleep, they wake up, and they want to work and feel good during the day and think and remember and have good motivation. So all these things are important. The Epworth score, the modified FOSQ, is another fatigue severity score. These are all, even insomnia index, all of these are potentially useful to help us to assess qualitatively what's going on in the patient. So yes, we do an Epworth score, fatigue severity score, we do a FOSQ and a fatigue severity score, an insomnia index when the patients come in.
Excellent. And can you talk a little bit about combination therapies? Like, how often do you see like adding an oral appliance or adding positional therapy? Is that common or not in your practice?
No, yeah, that's a good. I mean, I think it's relatively uncommon. The biggest is if 25% of patients don't tolerate CPAP, and another 20% kind of tolerate it. So we have stars, maybe 55% in my clinic that are stars. They use it, they understand it, and but we have 25% that can't use it. So we have to look for alternative therapy. And we will try oral appliance or hypoglossal nerve stimulator in those individuals, or weight loss therapy, particularly now that we have tirzepatide available, and maybe even upper airway modification, though that's upper airway modification. Tonsillectomy is typically more in children. So yeah, we talk about all those. Now, some of the patients may require fairly high pressure or maybe positional. If they are, we may use an oral appliance, which will decrease the upper airway pressure. Sometimes we even use an oral appliance in our Inspire hypoglossal nerve stimulator patients. So it's not uncommon in the troubled cases to sort of use combination therapy, but CPAP, BiPAP, all these other PAP devices are generally, at least 55% of the time, work pretty well, and then we have to problem solve those other patients in certain situations to try to allow them to adapt.
Fantastic. Let's move to the audience Q&A. Dr. Gradney, I'll send this question to you first. I send via email the Epworth Sleepiness Scale to my patients prior to their first appointment. Any comments regarding its efficacy when answered at home or in office?
Thank you. So, my first blush on this would be really that a subjective scale like that really shouldn't have any difference in response, whether it be done in the clinic or at home. So I think my first consideration would be no, it's just as effective or ineffective, depending on how you like it. But as I think about it a little bit more, I think honestly, there are a lot of times that the patients misunderstand the Epworth or factor other things into it that are not really intended, or maybe think about the time frame a little bit differently than what's intended. And so I do think that being available for some clarification can significantly impact the answer. So I'm not sure if that answers your question or not. It really, in reality, should not affect the response, but living in the real world, there is some clarification that needs to be made occasionally. If I was in that situation, one thing that I may consider doing is, along with the Epworth scale, send a frequently asked questions sort of sheet along with it, just to clarify some of the common misconceptions.
Yeah, my answer to that, I agree. It's a patient-reported outcome measure, and it takes about 30 seconds to do it. So it doesn't hurt, particularly if the patient knows. First time they did it might take longer, but after they get used to taking the test, So there's not much advantage in doing it at home, to be honest with you, unless you're just tracking them over time and having them report. But it's a patient-reported outcome, subjective. As long as they understand the questionnaire, they can do it wherever they want to.
Dr. Bogan, how frequently are you ordering actigraphy in your practice?
I wish we were ordering it more. Actigraphy is very beneficial. We do sometimes use a surrogate signal for that, so people's their watches can give us some, or their ring can give us some information. I'm really more sort of interested in what time they go to bed and get up, and how much opportunity they have to sleep. But actigraphy, certainly in circadian rhythm abnormalities or insufficient sleep syndromes, is beneficial. And I would do it more if it were affordable. There's no reimbursement for it. The devices are not inexpensive, and sometimes they disappear and don't come back. So we do rely on patient-reported measures as well as some of the, wearable technologies to try to get some idea. Patients are terrible at reporting total sleep time, though. We were amnestic when we were asleep. We just remember when we were awake. And so they under-report total sleep time and over-report sleep latency and wake after sleep onset. So they're not particularly reliable, but I focus on the opportunity to sleep. What time you get in the bed, what time you get out, and then, how much sleep. I mean, I don't ignore, but how much sleep do you think you're getting? But we do have to remember the CPAP is measuring breathing when the mask is on. So it's not sleep time, it's wearing time. So we have to keep that in mind as well.
Dr. Gradney, did you want to address actigraphy?
Yeah, I share a lot of the same thoughts. I mean, honestly, we would use it more if there were more affordable devices, if we had better mechanisms to make sure that the devices didn't get broken or disappear. If we had more reliable devices, to be honest, whenever we use this in my practice, oh gosh, and this may be a not a great comparison because it's so long ago, but 8 to 10 years ago, the devices were broken half the time, and the reimbursement really is an issue. And then to Dr. Bogan's point, sort of the ability to interpret the data and to directly link that with the clinical outcomes that we're actually worried about is maybe somewhat lacking. And so we do not pursue actigraphy very often in my clinic.
Understood. Some of our patients have initial good reaction feedback to PAP therapy, then maybe after 2 to 3 months, they seem to have the same initial complaints: daytime sleepiness, fatigue, headaches, etc. Most of the settings are already at max, and the the machines are auto, whether BiPAP or CPAP. What else can I do for these patients? They do have good compliance.
Yeah, go ahead.
No, go ahead.
All right, perfect. Yeah, I guess first of all, the one thing I'd say is if the settings are already at max, that would be strange, right? Rarely do I actually max out settings for a PAP patient, but I think that's sort of beside the point of the question. What I have noticed, a phenomenon that happens in my patient population quite a bit, or these patients with undiagnosed sleep apnea come in with very large sleep debts. So they are able to fall asleep immediately because they have such a long sleep debt because they've been essentially sleep deprived or sleep fragmented for so long. So you stick them on PAP therapy, they have this amazing response where they just say, oh my gosh, this is the best sleep I've had in years and years. So part of that is a phenomenon of rebound sleep, where for a few nights they're actually going to have increased stage 3 sleep as part of a catch up from their long-term sleep deprivation. The other part of it is just that they're getting better quality sleep in general. So the problem that I think this question is getting to is that at some point this patient's sleep normalizes, and they actually need to do all of the things that a person without a high sleep debt needs to do to sleep appropriately. Whenever you have untreated sleep apnea and a very high sleep drive because of your sleep debt, you can do everything wrong and still fall asleep. Whenever you have adequate and good consolidated sleep, your sleep drive's not that high anymore. Now you need to put the phone away. Now you need to stop drinking caffeine in the afternoon. Now you need to exercise. Now you need to go to bed at a consistent time. Now you need to start doing all the things that, I kind of say to my patients, I say, well, welcome to the real world. Sleep's not easy. And so you have to put in some work in order to get better quality sleep. So I think that's a phenomenon that I've seen several times in my patients, and re-educating about sleep hygiene and sleep scheduling really can help get that patient happy again.
Yeah, I would completely agree with that. I think it's spot on. I call it the halo effect, and the brain has so much trash in it. Adenosine takes, according to Tom Roth's studies looking at MSLTs, takes about 2 weeks to get the trash out. So the halo effect is, now I'm better, but I'm still sleepy, and you may see them back in 2 or 3 months or 6 months or whatever, but they're still sleepy. So I think it's fair to sort of say, hey, they're bad. They never go back to as bad as baseline, but they were better, but they're not where they want to be. And of course, that's when we start considering using medication to upregulate those monoaminergic neurons to give people less fatigue and less sleepiness.
Fantastic. Well, thank you all so much for attending today's event. We are at time and I'm feeling much more informed. I hope all of you are too. You are welcome to reach out to me, Sri Roy, editor of Sleep Review, with comments at editor@sleepreviewmad.com. And please take the exit survey that will pop up when you leave today's event. Thank you for joining today's webinar, Solving the Residual Sleepiness Puzzle, Managing Daytime Sleepiness in Treated OSA Patients.